Very good. So this is the last section of this session, and I will be given the task of really dealing with the often forgotten stepchild of our MI classification system. And if I bring us back to the overall schema of the clinical classification that exists within the third universal definition of MI, I've been tasked with discriminating between type 1 and type 2 myocardial infarction. And Joe Alpert has many times said this, and the last time was at the ESC, where he pointed out that out of the 5 subtypes of MI in the revised universal is proven the most difficult to interpret and therefore to implement. And I think that the rest of the committee got together after I had left, drew the short straw, and handed it to me for this talk. But I actually think it's an important and valuable challenge because this is really, in my opinion, the major area where we still have more research to do in the coming 5 years. And there are 3 key questions I ask as a clinician and a researcher when I try and discriminate these 2 MI types. I ask, can I tell them apart? And I'll start up front by saying there's no gold standard, as I'll show you. But I'm not a nihilist. I think it is possible to use clues and to identify patients with likely type 2 myocardial infarction. You need to understand how often they occur, and I want to make the point up front that it really depends on the clinical setting. And I'll show you the wide estimates of the frequency of type 2 myocardial infarction across a variety of settings. And then the last question we all face is, what should I do about one if I detect it? And the therapeutic implications are largely untested. And this is a key area of research, but I think it is possible to take a common sense approach using the best available data so far. So with that construct, we'll start with spontaneous myocardial infarction, which is type 1 in the universal definition. And I think the key element here is that this is, the cause is intraluminal thrombosis due to an underlying coronary abnormality and leading to the decrease of myocardial blood flow and ensuing myocyte necrosis. Type 2 myocardial infarction is secondary to ischemic imbalance as it's defined in the universal definition. It's often been referred to as demand myocardial infarction, but that's a little bit too narrow, as I'll point out. It's really secondary myocardial infarction, and I'm going to point out that when I always tell my residents that it's not acutely atherothrombotic. Type 2 myocardial infarction in some ways is defined more by what it's not. Again, there's a requirement that there's underlying myocardial ischemia with necrosis, evident by elevation with a rise and fall, as Dr. Jaffe pointed out, of a cardio-specific biomarker. And it's due to that rise and fall, that ischemic imbalance is due to a cause other than coronary atherothrombosis, contributing to imbalance of myocardial oxygen supply and demand. And then we have a long list that we encounter in clinical practice of things that may reduce supply: anemia, respiratory failure, bradycardia, hypotension, coronary artery spasm, and as Dr. Jaffe already mentioned, severe coronary endothelial dysfunction. We also have other conditions that can cause an abrupt increase in myocardial oxygen demand, such as tachyarrhythmias and hypertension. But all of these are a bit difficult to define with specific criteria. And I think the cartoon that Joe Alpert and others on the committee developed for this differentiation really is helpful. A picture is worth 1,000 words. And so these are the 3 predominant conditions: vasospasm and or endothelial dysfunction, a fixed underlying coronary obstruction without overlying atherothrombosis, where ischemia ensues in the setting of supply-demand imbalance because of an increase in demand, or supply-demand imbalance alone at the extremes of those conditions. And we'll come back to some examples of that. But really what we're trying to do is discriminate it from acute plaque rupture and thrombosis, as one of the questioners asked early on in asking about non-STEMI versus STEMI, and when we confuse the potential treatment for type 2 myocardial infarction with that from type 1. And this task, though, is not always easy. So consider this case. This is a 69-year-old with diabetes, hypertension, a prior myocardial infarction, a reduced ejection fraction, who presents with acute substernal chest pressure, is found in your emergency department to have atrial fibrillation with marked tachycardia, and has ischemic ST changes. This may very well be a demand-related myocardial injury with a rise and fall in the presence of ischemic symptoms and ischemic ECG changes because the patient had atrial fibrillation, or it very well could have been acute plaque rupture, thrombosis, and AFib in that setting. And it's often very difficult to discriminate, and I think this is a patient where we likely would take that patient to the cath lab and define the coronary anatomy, but there are many others along this spectrum where invasive evaluation may not be appropriate, where we have to make judgments. I'll come back to the key point that Peter Clemenson made earlier as well, that the diagnosis of myocardial infarction is made in the setting of evidence of ischemia, and so there needs to be symptoms, ECG manifestations, imaging, or otherwise, and that is true for type 2 myocardial infarction as well. But we do encounter cases where we have intubated patients in our ICUs who are unable to report ischemic symptoms, where we're still caught in this conundrum where our typical tools may not have the same level of sensitivity that we do. So clinical reality is not always precisely as we would try and capture in the definitions. So I'd say at best we have clinical clues rather than firm criteria at this point for type 2 myocardial infarction. And I think the most important is really at the bottom, which is that we are trying to identify patients with type 2 myocardial infarction as having an absence of a non-thrombotic cause. The typical pattern of onset may be helpful in type 1. Ischemic ECG abnormalities at normal heart rate and blood pressure, as opposed to type 2, where there's presence of an identifiable cause of supply-demand mismatch. And that, I think, is the most important element, that the heart rate and the blood pressure may be plausibly consistent with increased demand, and that the symptoms or signs of ischemia are situational, such as in the setting of tachycardia in the postoperative state, rather than existing at rest in bed with severe chest pressure that's been crescendo over the preceding week. Diagnostic coronary imaging obviously is helpful in that circumstance, but not always something that we pursue. So there has been a definition with specific criteria that have been used. These data come from Lotte Sabi and work done by Professor Tikkanen at one of our chairmen in Denmark, and this was a definition that they used. I'm not going to go through all the detail, but simply to point out it's difficult. Because, for example, for increased demand, they used a systolic blood pressure of above 160 and concomitant left ventricular hypertrophy. But for a patient with severe diffuse coronary artery disease, you might have demand-related myocardial ischemia with a blood pressure of 155. And for a patient with relatively normal coronaries, you might have to get to blood pressure of 195 and have severe LVH. So they're very reasonable to have selected a definition for a clinical study, but it's difficult to use something that's going to be universal across all patients. And then discriminating from the type of injury that Dr. Jaffe described at the beginning of this session, so discriminating type 2 myocardial infarction from other causes of myocardial injury may be even more difficult. And so here are a few case examples. I don't have answers, but these will give you the intuition of where we face the challenge. So a 69-year-old patient with multiple risk factors who's admitted to your medical intensive care unit with sepsis and a heart rate of 130. That patient very may have a type 2 myocardial infarction from increased demand and underlying fixed coronary atherosclerosis. Or this could be myocardial injury from sepsis that's been well described in the presence of the inflammatory cytokine surge that we see in the absence of underlying coronary disease. A 54-year-old with ischemic cardiomyopathy who presents with chest pressure and decompensated heart failure could be a type 1 atherothrombotic lesion, could be an increase in myocardial wall stress, or could be progression of myopathic changes in the patient with an myopathy. It's often difficult to discriminate. 72-year-old with diabetes and no symptomatic coronary disease who on postoperative day 1 has a typical rise and fall, a 40% change in cardiac troponin after what was thought to be an uncomplicated colectomy. This could be a demand-related myocardial infarction, or there may be other causes of myocardial injury in this perioperative setting that we still have to learn about. And then lastly, a slightly different case, an 18-year-old woman, this is one of Joe Alpert's favorite examples, with WPW, who presents with a prolonged SVT. Here, the mechanism of injury isn't so difficult. Do we call this an MI? It's ischemic, plausibly an etiology, but presumably no underlying coronary abnormality. And that's an important element of the definition that I think we still may flesh out in more detail in future iterations. And as Dr. Jaffe pointed out already, I think these cases illustrate that there's overlap between causes of injury and causes of myocardial ischemia, ischemic injury that embrace type 2 myocardial infarction, and clinically it's often difficult to sort these out. So how often does this occur? And a study that our group published in 2009 was among the first to do so. We studied specifically patients with acute coronary syndrome and the recurrence of myocardial infarction, and not at all surprisingly, in a population that had just been hospitalized with an acute coronary syndrome, when we looked at new MIs over the ensuing 18 months, type 2 myocardial infarction was a relatively small contributor because these patients were at highest risk for periprocedural infarction and type 1 spontaneous myocardial infarction. At this meeting, we presented long-term follow-up in a large cohort, nearly 26,500 patients with stable atherosclerosis, and looked again at the occurrence of type 2 myocardial infarction, and here we see it's about 10% of the myocardial infarctions that occurred over a period of 2.5 years on average in this patient population, so a higher proportion that we might expect. But then let's look at some other areas. So if we test all comers and look at all patients in a hospitalized setting who have troponin measured, there the incidence of type 2 myocardial infarction is much higher, estimated here at 30%. And if you take all comers to the emergency department who have elevated cardiac troponin and examine their final diagnosis, in one study it was estimated to be as high as 70% of the myocardial infarctions were reported to be type 2. Now, I do want to illustrate the challenge because these two studies next to each other are from the exact same hospital, just at two separate points of time. And it's very unlikely that the distribution of disease in their emergency department changed that dramatically, but more likely the way the definitions were applied. And that, I think, illustrates still the need for some evolution and, as best we can, clarity in the way we apply the definitions. So lastly, do these myocardial infarctions matter? We've heard about type 4 myocardial infarction, we've heard about spontaneous myocardial infarction, and these data come from our ACS trial again, and what we saw was that type 2 myocardial infarction do carry prognostic implications. And so there was a threefold higher rate of mortality over the ensuing 6 months in patients who had a type 2 MI compared to those patients with no recurrent myocardial infarction. Probably less, I say probably in this study, than spontaneous myocardial infarction, but on the same order of magnitude and not statistically different. We also, just in the past 2 months, have new data again from Ladasabi and one of our chairmen, studied a large population of patients in Denmark, hospitalized who underwent troponin testing. There were 488 myocardial infarctions, 24% of them were type 2, and you can see these patients were in red, and their survival was worse than those patients with spontaneous myocardial infarction, and this has been reflected in at least one other data set as well. Now, importantly, it may matter the cause of the type 2 myocardial infarction, and this hasn't been necessarily true across all data sets, but I think important for us to pay attention to. So in those patients who had type 2 MI in the setting of shock or in respiratory failure, Understandably, those patients had a higher rate of mortality. In contrast, there was no difference between dead or alive if the cause of type 2 MI was anemia in this study, or bradyarrhythmia, or even ventricular tachycardia. And so the cause of type 2 MI might also matter in the prognostic implications, and I think that's something we have to study going forward. And so then lastly, the management of type 2 myocardial infarction. We just have very few data. And so because of that, we have to do the best that we can and use common sense. And my approach is that I always treat the underlying problem first. If it's tachycardia driven and the tachycardia is inappropriate, then I'll manage that. If the reason they're tachycardic is because they're septic, I will treat their sepsis primarily. It may be reasonable to use pharmacotherapy to reduce myocardial oxygen demand, but you have to make a judgment of the circumstances. Certainly we would treat coronary vasospasm when that is suspected. And for the acute diagnosis and management, so do I pursue a coronary angiogram? Do I start unfractionated heparin if I'm in doubt as to whether this is type 2 or type 1? I think about their global risk if this is type 1. If this is a type 1 MI, is this patient one who's at highest risk for progression, cardiovascular death, recurrent myocardial infarction? That's a patient where I'm likely to treat them or evaluate them invasively. My final diagnosis may be type 2 MI. That's okay. And then also I tailor my treatment to the clinical setting. I'm not going to start heparin in a patient where I think the type 2 MI is because of their GI bleed. For long-term management, I consider additional risk stratification. The patient who has an MI with a heart rate of 120, that tells me something about their underlying coronary anatomy most likely, and I'm likely to evaluate them. And my last note before I come to conclusion is that it is very interesting. We have 2 clinical trials now, randomized trials of antiplatelet therapy. And in both of these trials, we actually saw that the effect on type 2 myocardial infarction with antiplatelet therapy was similar as it was to type 2 and type 4 MI. And that raises the question of whether there still is some thrombotic component, perhaps in the setting of sepsis where we know the thrombotic milieu is activated, perhaps in the setting of the postoperative state where we haven't fully sorted out all the causes of type 2 myocardial infarction in that setting. So we shouldn't dismiss completely the effect of antiplatelet therapy and antithrombotic therapy, but clearly it's the demand and supply mismatch that we're focused on. So how can I tell these type 2 MIs apart? It's difficult to develop a gold standard, but I think you can use your clinical interpretation of the entire picture, the absence of coronary thrombosis if you know it, and the most important, that there's a plausible increase in demand or a decrease in supply. How often do they occur? It is very variable, from 3.5 to 70%. I think we have a lot to learn, and we really need to understand the population in which you're studying it, because that's going to apply to how often it occurs. And what should I do about them? Common sense approach is where we stand right now. And then I think there are a number of additional areas to be addressed that the numerous speakers before me have identified, including how can I have an MI without this being an acute coronary syndrome? And we need to think about that terminology and how it plays out in our ICD coding and our epidemiological interpretation. So a lot more to do with this syndrome. I thank you very much for your time.
Thank you, David, very much for this elegant overview of a very difficult topic, which I don't think the last word has been said. Do you have a word about?
Yes, well, first of all, I wanted to congratulate David. That is the best talk that I've heard, including all that I've ever given on differentiating type 1 from type 2. So this is now the platinum standard in this area. The important point I think that you made just beautifully is that there's just so many unknown variables in the setting, so that in each of these patients it has to be an individual decision. And as I was watching you go through the thought process, That's exactly what I go through, and I'm sure you do too. You're on the consult service, you're being called by pulmonary or GI or OBGYN. This patient has an elevated troponin, what are we going to do about it? Should we run for the cath lab? And it's exactly that same, what is the setting, what is the likelihood of coronary disease, what is the likelihood of an atheroembolic complication in the coronary. But I predict that we will never totally solve this because the clinical situations are so diverse and there's so many variables. Again, it comes down to the thing, that our grandfather physicians told us: use good clinical judgment, careful thought, rational thought about the situation, and come up with a plan. And I know, with respect to therapy, the house officers always start statins and aspirin usually. And of course, we have no evidence, but the likelihood that they're going to hurt somebody with those two drugs is very low. So I think it's okay, but this is yet another area where we need some good clinical trials. Outstanding talk, David.
Thanks, Joe. I agree with this statement. I think ultimately it's not possible to solve. There's no single solution. I think that we still, and also it's good that we can't be replaced by robots and computers, that ultimately you have to use that integrated judgment. I do think because many of us as a trialist, we face the need to adjudicate these in clinical trials, which is often challenging, that there will be value in continuing to refine our definitions as best as we can, but ultimately it's still going to require human adjudicators to make some judgment.
Well, I know you did say that there's no particular ICD code for type 2, but I think what we all face in clinical practice is what codes are you using for these type 2 MIs? Because you're wrestling with the coders saying, oh, every time you write type 2 MI, we're going to code it as an MI. And then you have the value-based purchasing, which throws another wrench in it because you have all these patients with sepsis having type 2 MIs, and then your hospital looks bad because you've got a high MI mortality when it is really, and so we're trying to tell them, do not code this as an MI, even though we're writing it as a type 2, and the coders feel they've got some consultant who's saying, as long as the doctors write MI, you've got to code it as an MI. So how do you address that, and how do you kind of get with quality markers in terms of MI mortality?
Yeah, so I think you've identified a key challenge that we face. I definitely don't have the solution. I welcome others from the committee to also give their opinion. I think I would say that, in my practice, I tend to be somewhat descriptive in that I will say that this is definite myocardial injury in the setting of X. And if I think it's a type 2 MI, I will often put type 2 MI as well. But I use a descriptive framework in what I do in my clinical notes. And you're absolutely right. It's a real challenge. It's a real challenge.
One more, please.
Hi, Vic Tandon from Canada. Myocardial injury post significant blood loss. What's your threshold in terms of transfusion, and how aggressively do you transfuse, knowing that transfusion itself can be troublesome at times?
Yeah, I think it's an excellent question. I think they're really individualized for the patient. I think that because those patients may have other reasons for ischemia in the setting, if I think that it's due to severe critical underlying disease and they've had myocardial injury because of that, then I'm likely to use a low transfusion threshold because there's been myocardial injury. But I will say that I don't routinely transfuse to another level because of a type 2 MI in and of itself. But it's a good question. It's one of the areas we probably should study.
We used 5.5 millimole per liter in the study you referred to, but that can be discussed as well, of course. Well, I think we are moving now towards the end of a very interesting session. Thank you very much for attending. And we have not said the last word. The Universal Definition Task Force will go on forever, I think.